Okay, so this is our monthly community of practice that we have here with Impact West Virginia. And today I would like to introduce Dr. Danielle Davidov, and she's an associate professor in the Department of Social and Behavioral Sciences here at WVU. Her program of research centers on using qualitative and mixed methods to address intimate partner and sexual violence in home visitation, healthcare, and college settings. She has served as a qualitative lead and co-investigator on numerous statewide evaluations to improve health disparities related to substance use and mental health in West Virginia. With the West Virginia Coalition Against Domestic Violence, she is currently the co-lead for a patient-centered Outcomes Research Institute funded project aimed at improving the healthcare system's response to intimate partner violence in West Virginia. Within the School of Public Health, she mentors undergraduate, master's level, and doctoral students and teaches courses related to intervention design, qualitative methods, social determinants of health, and public health prevention. So I welcome you all today. Again, if you please put your information in the chat. We thank you for joining us, and I'm going to turn it over to Dr. Davidov.
Everybody, thank you so much for having me today. I'm excited to chat with you all a little bit today about domestic and family violence. I'm going to go ahead and share my screen. And I'm excited to do this discussion. I'm actually seeing some names that look familiar to me from some of the work I've done in this area throughout West Virginia, particularly in home visitation. So that's pretty cool. And if you have questions, feel free to put things in the chat. I'm okay at sometimes monitoring it while I'm chatting. I might not get to it until the end, but either way, if you do have something in the chat, I will get to it before the end of today. So again, my name is Danielle Davidov, and I work in the School of Public Health. My background is in psychology and public health, and I mostly do research in this field that I'm going to be talking about today. So I'm excited to share some information with you. And so what I'm going to be talking about today is a little bit of introductory information about domestic or intimate partner violence, probably things that most of you working in this field probably know. And then I'm going to get a little bit more specific and talk about associations with maternal and child health. And talking a little bit more in depth about children's exposure to domestic violence, and end with some prevention and intervention strategies, and talk a little bit about intimate partner violence within the context of home visitation. So I wanted to start out with a slide from the Centers for Disease Control that really shows the different forms of violence that can occur across the lifespan. And so you can see that many different types of violence can occur and can happen to us throughout our entire lives. The ones that I'm going to be focusing on today are mostly intimate partner violence, which you can see occurs mostly in late adolescence through adulthood, and then child maltreatment that can occur during childhood and into adolescence. So just starting out with some basic definitions. When we hear the term domestic violence, most people don't associate that with a very broad definition. We usually think of that as what I'm going to refer to as intimate partner violence. But technically, domestic violence could be any type of violence or abuse that's occurring within a household. So that could be actually child abuse. That could be violence that's occurring between two non-related roommates, or that could be violence happening between two adult family members, for example. And that's compared with what we know as intimate partner violence, which is sexual, physical, or psychological harm by a current or former partner or spouse. And intimate partner violence, which I'll refer to as IPV for the remaining presentation, this really can occur between same-sex partners. This can occur between individuals who have not been sexually intimate. So this can occur in the context of any type of romantic relationship, be it one date or within a marriage or former marriage. But a lot of people, specifically folks working in the field of social work, home visitation, refer to intimate partner violence as DV or domestic violence. So really these terms are used interchangeably. I'm primed to say IPV, so I'll probably refer to it as that, but do know that I'm talking about domestic violence as it's referred to by a lot of people. So I'm going to briefly mention the different types of IPV. These different types of IPV often overlap and co-occur. And so we have what a lot of people think of as typical domestic violence, the physical violence, right? But we also have sexual violence, stalking, psychological aggression, or what some folks might call verbal abuse, and then reproductive coercion. And I'm going to talk very briefly through each of these. So physical IPV can be anything, from minor injuries all the way to death or a lethal injury. This can be slapping, pushing, shoving, beating, burning, choking, more severe forms of physical violence. This can encompass assault with objects or weapons, and then any type of act that might threaten to maim or kill, or actually an act that hurts or harms pets, a partner, or family members would be considered physical IPV. The most common forms of physical IPV that are seen in abusive relationships are things like strangling, biting, burning, and throwing. Also, sexual IPV can occur. So this would be any type of sexual coercion, harassment, completed sexual assault or rape, or any type of unwanted sexual contact that occurs within the context of a romantic or intimate relationship. Interestingly, for a really, really long time, this occurring within the context of a relationship was not considered to be a criminal act or count as assault or rape. So if it occurred within the context of a marriage, nothing criminal would be considered, you wouldn't be able to prosecute it. The person that was assaulted or raped wouldn't really have any rights if they were married and their partner is who perpetrated this against them. So we've come a long way since then, but really 1993, that wasn't that long ago for this change to have happened. And then psychological aggression, which is certainly the most common form of IPV. This might also be called verbal abuse or emotional abuse. And this is any type of name calling, intense criticism, coercive control, any restriction of a person's routine, relationship, activities outside, or making one or medical care. That's a common form of emotional or psychological aggression or manipulation. And then threats to harm loved ones, and then economic or financial abuse. So if one partner is controlling all of the money in the household and will not let the other partner have access to funds, that can be a form of psychological abuse. And then there is stalking, which is more recently recognized as a form of intimate partner violence. And so this would be harassment or doing anything threatening to a partner that might cause fear or concern. This occurs often when folks break up. So stalking a former partner still would be considered a form of intimate partner violence. And so typically we might think of stalking as happening when someone lurks outside of another person's home or apartment, or comes to their workplace, or even calls them repeatedly. But now what we're seeing is, especially among the younger populations, intense stalking through social media or the internet. And that might be, if we're talking about Facebook, friending someone and unfriending them over and over again so that it makes a notification on their account, and so they have to see it and they have to respond to it. And so people are becoming very creative with the ways that they are stalking or harassing people on social media. And I will say that I don't think that the law and the legal system and protections that we have in place are up to date on protecting people from this. It's still really new in terms of how do we protect people from this social media exposure and stalking. And then the last form of intimate partner violence is reproductive coercion. And this again is recognized as a more newly recognized as a form of IPV. And this would be when one partner tries to influence or control the reproduction of the other partner. That could be pressuring one partner to get pregnant when they don't want to. That could be sabotaging birth control, such as in the picture here, poking holes in a condom, flushing birth control pills down the toilet. This concept of stealthing that you may have heard of, that I've heard more recently in the media, where a partner removes their condom without the other partner knowing about it. That's called stealthing, or controlling any pregnancy outcomes. So forcing a partner to get an abortion if they don't want to, not allowing a partner to get an abortion if they do want to, lying about being on birth control. All these things can be considered to be a form of reproductive coercion. So the thing that I want to really make clear about IPV is that usually when these things occur, they do not occur in isolation. They do not just occur one time. When we're really talking about what we all think of domestic violence or intimate partner violence, it's all about power and control. And these types of abuse or strategies, patterns, they happen not usually in isolation, not usually one form of violence occurs. So it's rare, for example, that there's a relationship where only physical violence is occurring. Usually where there's physical violence, we also see that psychological aggression. Or if there's sexual violence, maybe there's physical violence too. So these things can occur, just one form of violence, but it's more common that more than one is happening in a relationship. Intimate partner violence also escalates in frequency and severity over time, and occurs, or people are at increased risk for this to occur in pregnancy. And so I'm going to talk at length about that here in a few minutes, as well as when there is a perceived or actual separation. And so what we know is that women especially are at increased risk of being hurt or killed after they separate from an abusive partner. And so that sort of speaks to the common language that we hear, well, why don't you just leave, or why don't they just leave? Well, really leaving is the most dangerous time for an individual. And what we know is that most people will have to leave a relationship and return 6 or 7 times before they actually leave for good. And so leaving isn't necessarily the answer, and it is certainly not considered the safest thing to do. A safety plan and lots of preparation has to go into that for that to be done safely. So certainly people are at most risk in an abusive relationship at the time that they're either planning to leave, thinking about leaving, or when they've actually left. And then I have some information about prevalence that comes to us from the most recent data from the CDC. And so the CDC has published some information about the prevalence of IPV, both in the US, and then they have information for individual states as well. And so here we see on the very left-hand part of the slide that the prevalence of rape, physical violence, or stalking in a person's lifetime, for women in the United States, it is about, I think that's 36%. And then for men, it's about 30% actually in the US. But then if we look at West Virginia, women in West Virginia, I think have a prevalence about 38 or 39%. And then men right in line with the national average for women there. So between 30 and 40%, both in the US and West Virginia, individuals report experiencing IPV in their lifetime. If we look at impacts of IPV, which I'm going to talk about in just a minute, but that's any adverse outcome that occurs from experiencing this, we see women report much more impacts, right, than men do. We see only about 10% of men report experiencing a negative impact. In West Virginia, women are reporting negative impacts, and then fewer among men. With psychological aggression across the board, we see about 1 in 2 individuals, men and women, both nationally and in West Virginia, experiencing that verbal aggression or emotional abuse with an intimate partner in their lifetime. So here's some graphics from the CDC, just showing those impacts, those negative impacts of violence. So 1 in 4 women who have experienced intimate partner violence also report injury, fear, concern for safety, or needing services. And 1 in 9 men in the US will report that as well. And here we can really see that disparity in need for services. So over half of women have reported feeling fearful, concerns for safety, and symptoms of PTSD. And you can see less than 20% of men across the board have reported those things. And that makes us wonder, is this because we know that violence perpetrated against women might be more severe and thus a negative impact might be expected? Or are men less likely to report some of these negative impacts of violence just because this is something that men typically don't, report about? They might say, oh, I'm not going to admit that I'm concerned for my safety. And the answer is probably that maybe it's a little bit of both, but there's certainly a need for more research in this area. And then in terms of severe physical intimate partner violence. So this might be being hit or hurt with a fist, kicked, having hair pulled, choking, suffocating, or having a weapon be used. We see that this is very prevalent in the United States as well. So almost 1 in 4 women and 1 in 7 men report having this happen to them at some point in their lifetime. So, these things are not rare. These are common. They're occurring at pretty high rates, and especially, among the population that most of you folks work with, at even higher rates as well. So I'm particularly interested in intimate partner violence that's occurring in rural areas and differences in rural and urban violence. And so, what we know is that rural IPV occurs as frequently, if not more, than in non-rural areas. But in rural areas, we know within a given relationship, IPV occurs more often and has an increased or greater severity than in urban areas. And so that might be because partners in rural areas are more likely to use weapons like a knife or a gun. And that then translates to a greater likelihood of victims in rural areas being killed by an intimate partner. So I think that the statistic is 1 in 3 homicides against women in rural areas are on account of an intimate partner. All that then goes into another rural barrier, which is that victims access medical systems and mental health systems much less frequently than they do in urban areas. So now I'm going to talk really briefly about, my screen just went crazy. 1 second. I'm going to talk really briefly about some risk factors for both victimization and perpetration of IPV. And so again, and I'm probably going to say this several times, but just because something is associated with IPV doesn't mean it's, definitely going to happen, or that, if I say being a woman or female is a risk factor for IPV, that certainly doesn't mean that men cannot experience it. This is just all about strength of association and what the research has said. So we do know that being female is a risk factor for victimization. Younger individuals are more likely to experience IPV than older individuals, as well as those that are unmarried or come from lower socioeconomic backgrounds. We do know that women of color are disproportionately more likely to experience victimization than white women and white men. And then I have a little asterisk here by history of violence, because we do know through lots of research that the single greatest risk factor for experiencing IPV in adulthood is when an individual experiences any form of violence or abuse earlier in their lifetime. So talking about, overlapping risk and intergenerational trauma and things like this, that's sort of the theme of what you're going to see a little bit today, is that what we experience in our younger life can certainly follow us through when it comes to violence and abuse. So if an individual experiences child abuse, they're going to be more at risk for IPV later in life. In terms of perpetrating violence, there's a lot of research on this. And again, just the caveat that just because something is a risk factor for perpetration doesn't mean that, for example, if an individual grows up in a household where they witness parental violence, they will be more likely to perpetrate violence, but it absolutely doesn't mean that they're going to. And so you can see the single greatest risk factors for perpetration of domestic or intimate partner violence are witnessing it as a child or being a victim of physical or psychological abuse. And then there's some other types of behaviors here that we know that are associated with perpetration as well. Now I'm going to move into some health consequences. Basically, any type of negative health outcome you can imagine, any body system issue you can imagine, domestic or intimate partner violence can impact it and can be associated with it. So if we had one room of people that had never experienced IPV, and then another room of people that had all been victims of intimate partner violence, that room with folks that have been victimized are going to be 2 times, 3 times, 10 times more likely to experience many of these health issues that are on the slide right here. So IPV can affect our minds, our bodies, definitely pregnancy outcomes that I'm going to talk about next. So just about anywhere you can imagine, or any type of health issue. Lots of research over the past several decades have found victims experience much greater negative health consequences than non-victims. And then there's some other correlates that are important that we see time and time again in research and in populations that are experiencing IPV. And that is there's a really strong correlation between substance abuse, domestic or intimate partner violence, and mental health issues, as well as lower levels of education and income, and having no health insurance or a lack of adequate health insurance. And so I know that many of you work with populations that might be accessing treatment for substance use disorder. And if you just look at these statistics, they're just alarming. So among women that access substance use disorder, if we ask about intimate partner violence or domestic violence, anywhere from about 50 to 90% will have endorsed that in their lifetime. And then in the past year, those rates are really, really high, anywhere from 31 to 67%. And then just giving a little bit more detail with the lack of health insurance. So we have a population that is certainly in need of services, more likely to experience lots of negative health issues and outcomes, and yet they are also more likely to not have adequate health insurance. So what we know about women receiving welfare, for example, is that in their lifetime, anywhere from 40 to 60% of them might report IPV. Current estimates are anywhere from 9 to 40%. So a really high rate for current or recent IPV. And then one study found that women experiencing IPV are 4 times more likely to be receiving medical assistance or have no health insurance. And we can see with the statistics here on the right that IPV is a very costly issue. It costs the health system a lot of money, the mental health system a lot of money, especially the emergency department and those types of health systems. And yet these types of things are not necessarily always covered by health insurance, and the folks that need to access these services might not be able to because of a lack of health insurance. Now I'm going to move into talking a little bit about pregnancy and the postpartum period and effects of IPV on children. And so just like we know that IPV is associated with adverse health outcomes for the victim, we know when the victim is a pregnant person or a young child, we're going to see lots of negative health outcomes as well. And I know this isn't the best graphic, it's a little bit blurry, but it does say that October is Domestic Violence Awareness Month. Maybe that's why you all chose to have this talk within October, but it does show a variety of negative health outcomes that are associated with IPV that I'm going to go over in a little bit more depth. So we know through lots of research that pregnancy is a time of increased risk for IPV. If IPV has not occurred in a relationship, this is a time where it might begin to occur. If it has already been occurring, this is a time when violence can be expected to escalate sometimes. Pregnant women especially are at risk for homicide during pregnancy. In fact, it is the leading cause of female homicide, or IPV is the leading cause of female homicide and injury-related deaths during pregnancy. And I think it might be the second leading cause of death among all pregnant people besides preeclampsia. So we have some prevalence information here. This has been studied at length. So across 92 studies, a prevalence has been found to be around 28% of pregnant people have experienced emotional abuse, 14% physical, and 8% sexual. So certainly pretty high for just one time in a person's life, that 9-month period. That's a very high percentage. And here's a graphic that I like that just kind of shows all of the different outcomes that can occur or that might be associated with intimate partner violence during pregnancy. And this would be for the person that is pregnant. So negative health behaviors, negative reproductive health issues, and then mental and physical health issues as well. And then some of these I'm going to go in a little bit more depth on. So we do know that IPV is associated with inadequate prenatal care. So those that have experienced IPV are 2 times more likely to not receive any prenatal care at all, and 2 times more likely to delay their entry into care. And this can result in a lot of negative neonatal health outcomes as well. So for folks that have experienced IPV, they have 5 times the odds of having a low birth weight infant, a preterm birth, or having a baby with intrauterine growth restriction. They have 4 times the odds of having a baby that is small for gestational age, and they have an increased risk for perinatal death. So not only does this affect the pregnant person, but of course can affect the child as well. And then I just wanted to make a point that substance use and abuse is certainly a risk factor for IPV during pregnancy. These things certainly co-occur. And according to a recent study, this author, Jameson, has said that substance using populations that are pregnant probably have the greatest difficulty accessing adequate prenatal care of any pregnant group out there. There are many barriers to accessing prenatal care. Fear of child protective services could be one, difficulty making or attending appointments, and then maybe ambivalence towards wanting to quit substances or feeling like they could quit substances during pregnancy, and feeling like entering into prenatal care is going to make that decision be forced. And then I know that when asked to give this presentation, I was asked to talk a little bit about the postpartum period and impacts on IPV's association with or connections to postpartum care, attendance at well visits. And it was really interesting to me as I was preparing for this. I really could not find much research in this area at all. I did find some things that talk about the postpartum period in general being a period of increased risk for IPV. In fact, we might expect that IPV might become moderate to severe in that period, but very few studies have really looked at whether or not IPV might impact how women receive care or medical care in the postpartum period. I did find one that found that among women that are over the age of 40 that were experiencing IPV, they had a significantly decreased risk of getting pap smears and getting mammograms. But other than that one study, I certainly did not find a lot of stuff. So there's room for more research on that one. In terms of postpartum depression and other issues that can occur in the postpartum period, we know that folks experiencing IPV are certainly more likely to experience all types of mental health issues, including depression. And so it's not super surprising that they're also more likely to experience postpartum depression. And I have this little research graph here on the slide that it's a little blurry too. And I only put it up to show that if we look at this line going right down this, this plot, it's called, at the number 1, if all of these dots, which are the different studies, were all along that line, that would show us that there is no association at all between postpartum depression and intimate partner violence. If they were on the left-hand side of this plot, that would show us that actually folks experiencing IPV were less likely to have postpartum depression. But you can see through all of these different studies, they're all on the right side of the plot, which means they are much more likely to have PPD. They might be 2 times more likely in one study, 5 times more likely. We see in one study, they were almost 8 times more likely to have postpartum depression. So in summary, in looking at all of these and doing a meta-analysis, we see they're about 3.5 times more likely to experience postpartum depression. And then pairing this with the fact that many may not be seeking services of medical practitioners and not receiving care from friends and family, this can be a real issue. Taking an intimate relationship where violence or abuse is occurring, and then adding postpartum depression on top of it, that can be a huge issue for mom, baby, and the entire family. I found some other predictors of postpartum depression that sort of have to do with the talk today, different forms of family violence, especially. So in addition to intimate partner violence, if a pregnant person reports that their partner has a problem with drugs or alcohol, that in their childhood, their parents hit in order to discipline, they had a household income lower than 40,000, I think this was Canadian dollars, or a personal history of depression. This was all, these were all predictive of postpartum depression at 8 weeks. And then in terms of breastfeeding, there has been a lot of research in this area as well. Some of the findings are pretty mixed, but many studies have found that exposure to IPV might shorten breastfeeding duration in general, result in early termination of exclusive breastfeeding, and might reduce breastfeeding initiation. One study found that being exposed to physical or psychological IPV reduced the likelihood of exclusive breastfeeding. However, there are some studies that have looked at this among large samples and found really no differences of breastfeeding among abused and non-abused women. However, we do know that conditions that are associated with IPV or domestic violence, like smoking, postpartum depression, PTSD, other mental health challenges, are barriers to successful breastfeeding. So it's really not outside the realm of possibility that there could be a strong connection here, and that IPV could be a barrier to breastfeeding. Okay. Also, I'm thinking about safe sleep and also, healthy infant development. I could not find a lot of information about IPV and safe sleep, which really surprised me. However, just like with breastfeeding, it's something that we could reasonably assume there might be something that's impactful here. So we do know that IPV increases stress, which impacts mom and infant sleep. One study, a very recent one, did find that IPV was associated with a 50% reduction in using a separate approved sleep surface among low-income families that were being included in a study. And then one examination of infant deaths from sudden explained infant deaths, so SIDS or SUIDS, I guess is the other acronym. In 9 of 27 cases where data were available, IPV was present. So that's pretty pretty high as well. So certainly that's an area where more research needs to be done. I think that this is probably one of those things where folks that are working with families receiving home visitation services probably might see connections here, but in terms of research and this being into the literature, I couldn't really find much information there. In terms of children's access to care, was also asked, if there's any connection to IPV with children's developmental screenings, going to well visits and things like that. I also could not find much about the connection between family violence or IPV and children's access of healthcare. Again, though, I think that it's reasonable to assume that there could be some type of connection there. There's also a growing literature about the appropriateness of screening for parental violence and children's exposure to violence within pediatric healthcare settings. And this is an area where we've seen a ton of new information in the past, I'm going to say 15 to 20 years. It's established that pediatricians and those working with kids know how to detect child maltreatment or abuse. They know what they're looking for. It's on their radar. They know what to do if they have observed a clear-cut case of this. We know that that's reportable. But exposure to parental IPV is a bit of more of a gray area, it's a trickier area to screen for and detect if we're talking about within the confines of children's healthcare. Now, I know at WVU Medicine, for example, this is done if you take your child to a pediatrician, they have that question that everybody's safe at home, right? Which that's a whole nother lecture we can get into and a whole nother presentation. But that is their attempt to screen for domestic or family violence within the context of the pediatric child setting. And regardless of how that's being done, it makes sense to try to address family violence within the context of children's healthcare because of negative impacts of family violence on children. So even when babies are infants, we see more fussiness, trouble sleeping, trouble eating, attachment issues in infants in homes where domestic violence is occurring. Certainly lots of negative effects among preschool age children, both emotionally, socially, behaviorally, and then those continue on into school age years and adolescence as well. And then, as I sort of talked about in the slide about risk factors for perpetration, we do know that boys who witness domestic violence are twice as likely to abuse their own partners and children. And then women that observe violence as a child are more likely to have a relationship or be in a relationship where they are abused. And overall, just all children that were exposed to violence in the home are 15 times more likely to be assaulted physically or sexually than the national average. So certainly some huge statistics here in terms of the intergenerational nature of violence and the cycle of violence that can occur within families. But I wanted to leave it on a less depressing note and talk a little bit about prevention and intervention strategies for violence. And I will say that unfortunately, we know a whole lot about the prevalence, the consequences, associations that IPV and domestic violence has with other issues, but we don't have a whole lot of really good prevention programs or intervention strategies. So when we ask, how do we prevent this? Or how do we intervene? And how do we reduce and stop violence? It's much trickier, and we have less information about what's really, really good and what really, really works, unfortunately. And so most of what we know about what works and what we need to do to intervene and to reduce and stop violence, what we know a lot of it comes from CDC. And we have this little chart that I like to use, and it shows primary prevention strategies, so stopping violence before it starts, and then secondary or tertiary prevention strategies. So we know that violence has already started, maybe abusive relationships are occurring, but how do we support people that have experienced it and lessen harms? So in terms of preventing violence before it starts, we know that teaching about healthy relationships is important. Engaging men and families in the discussion is important. And then really importantly, and I'm going to give a huge shout out to home visitation, is that disrupting that cycle of violence, disrupting the pathways that might set folks up to continue on with that trajectory of perpetrating violence. And so early childhood home visitation is one intervention. That is one strategy that has found to be effective at stopping the cycle of violence, at least when we're thinking of child maltreatment. And I'm going to talk here in a minute how home visitation has been used for prevention or reduction of domestic violence as well. And there are some other strategies in here that are important in terms of secondary and tertiary prevention. These are going to be things like providing services to victims, shelters and housing programs, and then screening or anything that's happening in the healthcare setting to detect violence. So I know many of you are involved in home visitation. And I actually did my dissertation on children's exposure to intimate partner violence and intimate partner violence itself within home visitation. So this is an issue and a program that is near and dear, or strategy, I should say, that's near and dear to my heart. So most of you likely know that here in the United States, home visitation is offered usually, not universally, but to the most vulnerable pregnant women and young families. And home visitation has so many amazing benefits, both prenatally for children and for moms and families. And so a few of the outcomes we know that home visitation can impact are maternal stress levels. So compared to families that do not receive home visitation services, those that get home visits are there's lower stress in the family, especially for the mom, a decreased prevalence of low birth weight and preterm babies, increased children's academic readiness and achievement. And this is something that's seen like 15 years later. So in studies that have looked at people that had home visitation and then talked to them again in 15 years, their children did better academically than those that did not receive the home visits. And also there's great benefits for mom education and employment. And then really importantly, there's solid evidence that home visitation can prevent and reduce child maltreatment and injuries from abuse within the household. So because of this, because of those really great benefits, there's been some research about domestic violence within home visitation. One study in 2000 found that in homes that are receiving home visitation services where domestic or intimate partner violence is also occurring, that all of these amazing benefits that I just talked about are not seen. They are not found if domestic violence is also occurring. So this led to a lot of folks saying, we need to do something about this. There's a huge overlap in homes where child maltreatment and IPV are occurring. So there's some shared risk factors there. In homes where child abuse is occurring, in 30 to 60% of the time, domestic violence might also be occurring. And among populations that receive home visitation, the rates of IPV are very high. So one study found about 48% of clients receiving home visitation services were experiencing domestic violence. So this is a huge issue, right? We have a population that's receiving these services. Home visitation is awesome and provides so many great benefits, yet in half the homes or the population, domestic violence is occurring, and domestic violence might make those benefits not realized. So there's been a huge push within the last 10 or so years to see can we and should we address domestic or intimate partner violence within the context of home visitation? So the Affordable Care Act actually provided a ton of money to do some studies to see if this could work. But there are not many interventions that are ready to take off the shelf and use within home visitation. So there have been some groups throughout the country and even internationally. One out of Johns Hopkins is evaluating the DOVE, or Domestic Violence Enhanced Home Visitation Study. And then there's one that I've been involved with called the Nurse Family Partnership Study, where they're really trying to create a new intervention that's training home visitors to truly intervene and do safety planning with families that might be experiencing intimate partner violence. The results of those, some have come out, some are still being published. They take a long time to do. So the jury is still out on, the effectiveness of these approaches, but they're definitely being examined. And then I was involved in an evaluation of West Virginia's attempt to integrate and address IPV in home visitation as well. And so I know that we had some really important discussions and exciting information come out of that evaluation as well. And I just wanted to end by talking about some of the secondary and tertiary interventions. I know that this might be where some of you are also kind of centered in doing your work as well. So this would be any type of intervention to support someone who's already experiencing violence and abuse. So this would be a shelter, information center. Sometimes home visiting can be looked at as a secondary intervention as well. Couples therapy or batterer interventions are often viewed as a secondary intervention. Unfortunately, those have been found to have pretty limited effectiveness. That's kind of like sending someone to anger management. If they have perpetrated violence, we haven't seen great outcomes from that. And then screening for domestic or intimate partner violence in healthcare settings is also a practice that really we're seeing a lot more of lately. And there's a lot of research out there trying to improve how we do that. So are you safe at home isn't our only question that we ask to do that. And so that we can ask those questions in a better way and really help patients feel comfortable answering that question truthfully so that we can connect them to services. And I wanted to end with this exhibit that I came across today. It was sent to my email. So apparently in the mountain layer, they are having an exhibition this entire week called Silent Witnesses, and it is honoring the men and women who were murdered by acts of domestic violence in West Virginia from 2019 to 2021, I believe, or maybe 2020 to 2021. So if you're local to Morgantown, this is at the mountain layer, and it's going to be set up all week. If this is something that interests you, I might try to pop by and take a look at it myself. I wanted to just say thank you to all of you for what you do. I know, with Impact West Virginia, I know many of you work with families who have children that have experienced neonatal abstinence syndrome. And 3 months ago, I had a baby and he was in the NICU for only 5 days for respiratory distress. And I was able to see firsthand what some of those babies go through, and families and nurses and doctors, just it was extremely eye-opening. And so I really appreciate the work that you all are doing and how you're helping the state of West Virginia. So just wanted to end there, and I'm happy to answer any questions or have more conversation about anything I've talked about today. And I am happy to share the slides and send those on so that you guys can have them if you want them. I do have some resources here, both local and national resources related to intimate partner and domestic violence. So happy to just share those. Thank you.
Thank you so much. And we had another comment. Would love to have the slides as you mentioned and the resources. So I think those are going to be great pieces to have.
Absolutely.
Any questions or comments? Anyone want to come off of mute or put it in the chat? We have a few minutes left. I did add a couple of HRSA resources that I found recently about the IPV, so those might be helpful to you. We also have a satisfaction survey. I put information in the chat. I'll send all of these things in a follow-up email for those of you that registered and I have your email address or that you've added it today. I appreciate how you made the connections to what we're seeing with the home visitors and even with impact with the substitutes. I think it's always interesting to hear how those connections and the intergenerational things connect. So thank you for that.
Yeah, very strong connections. It's almost like where one thing is, you should expect the other, right? If domestic violence is occurring, you might expect substance abuse to be occurring too. And having interventions and finding things to address all of those different issues can be really difficult.
And when you mentioned some additional training besides, or not training, questions or screening questions about are you safe at home, what are other questions that you see that are now being asked maybe in addition to or instead of?
Yeah, that's a great question. And the issue with are you safe at home is that it's so indirect that many people don't understand what's being asked. So oftentimes when are you safe at home is asked, people might think, well, sure, I don't even lock my door. My neighborhood is really safe. Or, you know what, my stairs are very rickety on my porch. I don't feel safe at my home. So there can be indirect questions, but that's so indirect that it's not necessarily measuring what we want it to measure. So a better question could be a direct question that if you're, let's say you're a nurse or a doctor in the healthcare setting or in home visitation, something like, we see really high rates of domestic violence in the work that we do. So now I ask all families about whether or not they're experiencing things like being hurt by their partner, right? So, and I didn't say that perfectly, but you can come out and directly ask, are you being hit, kicked, hurt, slapped, by your partner? So that's a very direct way of asking it. And some people in healthcare settings might choose to ask in that way. Or to say, all couples fight, what happens when you and your partner have a disagreement? And then sort of get some information that way. That's a more indirect way to start asking the questions and having the conversation. And then in the interventions in home visitation, they're using some really nice tailored tools. Things like little information cards to have the conversation, and in-depth tools that don't just ask about things like physical violence, but ask about, emotional abuse too, since that's something that's occurring much more frequently than physical abuse might be occurring. So it kind of depends on if you're in healthcare or home visitation or where you might be asking those questions, what might be the most appropriate thing. But oh my gosh, the are you safe at home? It's just, most of the time when I'm asked that, I'm not asked, they're just, you're safe at home, right? And then it's put in the medical record. So in the group I'm working with of intimate partner violence survivors, we're kind of brainstorming together how to improve that.
I think that's a good point and a good place to look towards improving.
Mm-hmm. Yeah, I agree. They know best, what we should be asking and how we should be asking and things like that.
Okay, anyone else have a question for our presenter today?
Yeah, I'm happy to send the slides, and I was kind of spotty with what I put references in and what I didn't. So if there's something that's in there and you want to know where it came from and it's not clear, I'm happy to dig that up.
Thank you. Okay, well, our next impact community practice, we're looking towards a November 7th and a December 7th date. So look for registration emails coming for that. We really appreciate you joining us today and hope you have a good rest of the afternoon and evening. Thank you all.
Thank you.